thank you for taking the time out this evening to attend and hopefully get some value out of this presentation around rebuilding your capacity, rebuilding your appointment books. The other thing that you'll also find is that Bertha didn't mention is that as well as accompanying the evaluation, there'll also be a copy of tonight's presentation made available to you. So hopefully you'll find that, and if there's any particular information that you also need, there's a contact number at the end or an email at the end of the presentation. So one of the main things, hopefully, some of the things tonight we're going to go through may talk about financial, and there may be a bit of accounting that I refer to. I'm not an accountant, I'm not a lawyer, but purely if what we can do is perhaps give you some questions that you may actually end up being able to ask those particular people if there's a necessity for it. The other thing, as Bertha said, I've been working with practices for about 30 years. I started off in radiology and corporate radiology. I've done out of metropolitan regional general practice. I've done CBD general practice, worked with a number of allied health, limited with specialists. But if I do default to general practice, that's because where most recently I've been doing work with a practice that I've worked with down in Tasmania. So I'm actually based at the moment in Tasmania, down in Port Huon. So we've been fairly fortunate here. We'll talk about the pandemic tonight with regard to what we as individuals have been able to do and move around, but also working with a practice that was well and truly involved in the whole journey of the pandemic. From tonight's presentation, hopefully what we're trying to do is allow you to understand why patients are booking appointments and maybe perhaps why they're not, why it's important that you connect with your past patients, looking at strategies as to how that may happen, looking at the need for new patients, and actually, do we actually need to attract new patients to the practice, at communication, and also around the whole way that we are providing services and the treatment paradigm for practitioners and staff, moving away from what we have become used to after so many years and what the MBS has actually supported with regards to face-to-face consultations. One of the things that I think, and I became aware of, and having spoken to a number of managers, a number of practices across Australia, is that I think as managers, we actually need to operate with kind of some baseline anxiety. So we actually need that adrenaline in order to drive us and keep us on our toes. What's happened significantly, though, since early this year, is that anxiety level has dramatically increased very, very rapidly with the onset. We sort of reached a peak, I think, around about March, April. Then we actually started to come down as some sort of certainty came back. Probably June, July, with the threatened outbreak, especially in Victoria, and the second wave, there was a massive increase in anxiety. I think as managers and owners, practitioners, we also had that, we weren't quite sure what was going to happen around the 30th of September. I always thought that they were going to maintain telehealth, but until they actually came out with the decision, we weren't quite sure what was going to happen. So hopefully now, once that's been confirmed through to March next year, what we're seeing is some sort of certainty coming in, some sort of certainty within our profession, some sort of certainty for patients, especially in areas excluding Victoria. So I think we're at a bit of a plateau now, and the next, hopefully we're going to be able to return to some sort of normality. But as I was talking to Bertha prior to just starting tonight, there's always going to be that, I think, that anxiety. Is there the potential for another wave? And I think That's always going to be on our mind, but hopefully we can put some strategies in place that will allow us to continue to perform at an appropriate level. The other thing which certainly has happened over the last 6 months and I've been involved in is presenting a lot of education around webinars, much like tonight. And it's interesting looking at where practices were and running polls across practices. What I actually found, this is probably up until July, there was about 15% of practices that had actually increased their income, but a significant number had actually reduced their surplus or their bottom line. And of that income that was increased, a number of that meant that there was probably about half the practices that were able or eligible for JobKeeper and about half that weren't. Now with the changes from 1 October, that's still, we've got to still wait and see if that's going to maintain. So even though some practices were increasing their income, it was actually the cost of providing services, the increased cost of meeting demand and what we were required to do in order to maintain safety for our staff and our patients and our practitioners meant that there was an increased cost to operating practices. So as I said, will this be the same as the 30th of September? We'll need to wait and see what's actually going to happen. So now getting down to kind of the crux of what we're going to talk about this evening, and really the last 6 months has been a bit like a game of snakes and ladders. You know, we've had the moving along pretty well, and then we've had some big wins where we've been able to do things, and then things like an increase in infection rate, and that has meant that we've just slid back down that snake and gone back to where we were. So what I'd like to, and how I'd like to address this evening is around what I call the 5 Ds. So I look at that as the first one being what we need to determine, what we need to decide, how we develop that, and then how do we actually delight our patients? And the 5th one we'll talk about when we get to the end. So I think the key thing, and I think one of the issues, and having worked in a CBD general practice associated with allied health and specialists, our patient cohort is significantly different probably to regional, rural, remote, outer metropolitan, because there is a fairly large transient percentage of our patient population that are utilizing those practices as their second practice or their major practice. That was changing with the urbanisation and bringing people back in the city, with especially in Melbourne, with units and buildings and that sort of thing. So I suppose what we need to actually do is actually determine where we are. It's an ideal opportunity now for practices to sit down and work out exactly where we are. So have we actually done that? We probably did it, or hopefully did it at the beginning of back in March, April, when the pandemic first hit. So hopefully now what we're going to do is actually sit down and look where we've come to and where we're going to go to. And in order to, so we need to know where we are, and we also need to keep well informed. And things like through the MBS online website, we can pick up up-to-date information around what's happening. And if we remember early on, one of the big issues that we had was things were changing so quickly, rapidly, that it was hard to actually plan and understand where we're going. More certainty has come into play. So at least now it would appear on the face of it that we have some certainty at least until March 2021. So it gives us, as working in the practice, the opportunity to start to do some planning. So do we know where we are now? And then also I think it's important how do we compare with last year, and how do we compare with our budget? Obviously, if we prepared budgets, we're going to be significantly different based on when we would have done it last year. Hopefully, we redid them probably, as I said, March, April, and looking at where we're going to. So we can actually look at a number of key items around how we're actually performing. So how is our income? How is our practitioners' workload? Is it up? Is it down? What's the mix? Is there private billing? Is there bulk billing? Private health, etc. Looking at our patient numbers, and then also looking at our appointment availability, and as well as our appointment availability, do we have an increased or a significant DNA rate from patients who are actually booking? So we need to understand where we are. We also need to understand who our actual patients are. So do we actually understand, and a number of practices either pre, post, or during pandemic may well not have gone through and actually understand what their patient cohort was like. What's our general age, gender, disease? As I said, having worked in CBD, and I remember there when we were in Melbourne that the cohort was 20 to 45-year-old, low rate of chronic disease, but more mental health. So we actually need to understand who our patients actually are. And what does that mix actually look like? We also need to look at the mix of what we're currently providing and how it may have changed between face-to-face consult versus telehealth, telephone. Now, there's no doubt, and I was sitting on a meeting earlier on today, and we're going and looking at some information that came out from the government and MBS regarding item utilization, and there is no doubt that telephone is by far and away the more utilized within that telehealth. So telephone, and I think it was something like 80 or 70 to 80% compared to video, which was a much lesser utilization. And there are a number of reasons for that. Do you have reasonable internet? Is your patient cohort able to manage video or telephone? So that's one aspect. The other aspect around looking at where we're going to go with regard to telephone versus face-to-face, we need to come up with some sort of strategy. We'll talk a bit about that in the next few aspects. But what we actually have to build, trust in our patients. Patients need to trust us. If we are going to go non-face-to-face, we have to build that trust and look at how we're actually going to do it. The other thing to look at, I think, is to look at what's our service analysis like at the moment. Historically, most practices, probably 90 to 95%, will be made up in general practice of 10 item numbers of particular services. If you're allied health, you'll know the particular speciality or type of area you're working within. Practitioners individually may have special skill sets, as some may have more focus on skin or procedural work, as opposed to others who do mental health, chronic disease, that type of thing. So I think it's important as a practice we look at and analyze the items and the services that we're providing. So we can look at what our top 5 items are that we may be billing, but importantly look at those that come after that top 5. So what's sort of 6 to 10 or 6 to 15? What are those ones that are on the fringe that maybe we can utilize or build on, increase to improve how we're actually providing or the range of services provided to the patients? So looking at those, and I think the other important thing is that we actually look at and establish what is our current rate of face-to-face, non-face-to-face. So it's getting a picture of where as a practice we actually are right at this particular point in time. So as we look to make plans and decide what we're going to do, we actually know where we are. It's not anecdotal. It's not, I think we're doing this. It's, this is where we are as a practice compared to where we were last year and compared to where we want to be. So critical to look at that before we try and do anything else. So once we've actually looked at that, I think the next part of where we're going is looking at, actually, I'll just go back and if Bert is online, if there were any particular questions in that particular area that have come through. It's just if people are putting, if you're putting questions up on the Q&A.
Nothing yet, Brett. But
okay,
if you do
cool.
have any questions, please type them in the questions box and we can get Brett to answer them.
Yep, and what I'll try and do is go through, and after each section we'll do it, and then we can also, if we don't get to it, we can have a general session at the end of the presentation. So deciding, so we've looked at where we are. Now what I want to do is decide what we actually want to achieve into the future. So what, and because we're looking at rebuilding our appointments, rebuilding our capacity, you know, what do we want our appointment book to look like? How do we want our appointment for our practice? And the thing is that for this particular issue, this is going to be practice specific, because each practice will have its own differing views, differing aims, differing objectives. So what you want for your practice is going to be the right percentage or breakdown for you. The example we've said here is, look, 85% booked, 15% on the day. So that's allowing for that on the day call, patient, drop in, etc. Now, because it's CBD, that could actually be 70% booked, 30% on the day. But it's what works for you, and you may want to look back at how it was previously or how it is now. So you actually want to quantify that per day, per week. And if we're saying we've got 85% booked, of those, we might say, look, we want 75% face-to-face, 20% on telephone, 5% video. So quantify what you actually want to achieve. Because if we don't quantify, then we really don't know what we're aiming for. So once we've decided on how we want our book to look, the next thing we say was, who do we target? Which cohort do we actually want to achieve? So if we're saying at the moment, we've said we want 85% booked, 15% of the day, we might be 60% booked. We actually have to get, how do we get from that 60 to 85? How do we get to where we want to do? So that's why if we understand who our patients actually are. So in this instance, if we're saying, well, we have a significant number of 75 plus in our practice, we have a number of chronic disease patients. We have particular GPs that are referring through to us who previously weren't referring through to us. We might have mental health patients, etc. So who do we actually target? And one of the key things may actually be that what we're finding and what was discussed previously was, look, and what's making it difficult, I think, with telehealth and people who haven't been in for that 12-month period, which would enable them, is that perhaps some of those people whose annual or cycle of face-to-face has occurred within that March to now basis where they haven't been coming into the practice. So we actually need now, because of NBS guidelines, to identify those patients and perhaps attract or contact them in order to get them in face-to-face so we can continue to build subsequent telehealth. We also might say, well, look, yes, we do have some chronic disease, so look at people from within, because it's far easier to communicate with patients who are already familiar with the practice than seeking to go out and get completely new patients. Because if we think about it, if your practice has a reduced number of patients coming through, it's more than likely that other practices are the same. So other practices will probably be looking to gain patients. And if we are all trying to get new patients, there is only a certain pool from which we can actually pull. So let's target our current patients and those that we have on our books. So we've set out, okay, these are the particular types of patients that we want. Next thing, how are we actually going to target them? Are we going to go, the SMS? Is there a particular case for direct telephone contact? Do we put an advertisement in the local paper? Have we got a Facebook page? I know of a particular practice, and it was in Sydney, where one of their, or a significant component of their work was actually occupational health and companies. So they physically went out, and the manager and one of their nurses actually went to practices, went to businesses to say, we are open for business, we can provide you with service. Remembering as well that if we've said we're going to target our patients that are on our books, and some of them may have already been on chronic disease or care plans or GPMP, and we're going to try and get them to come back in, then direct telephone contact could be useful by nature of the fact we could use a practice nurse to actually contact them and then bill a nurse item that's attributable to having a GPMP TCA. Talk a bit about that as well. And I think when we're looking at how we're going to achieve this, we need to be able to review. So we need to be able to say that we want to achieve this over a particular time frame. You might say we want to achieve the 85% book within 3 months, but it might be 75% within 1 month, 85%. So set targets and timeframes associated with those targets. So we've got something to aim for that you can actually quantify. And the other thing that's important is that this will cost money. So there is actually going to have to be some form of budget allocated towards this. Now that may be, as I said, it may be staff time. It may be, if you're on a particular plan with a particular provider, then the SMSs may not cost particularly, they may be included. Facebook, if you're doing that, there are ways. So I think it's realistic that yes, there may be a cost, but it doesn't have to be prohibitive. And often you can do it yourself within your practice. And then I think that the other bit around deciding is that we actually need to assign responsibility and to particular members of the team. They become accountable. Often we find that staff are, they all want this responsibility, but they need to be associated with that responsibility, have accountability. So we need to say, whoever it may be, your role over the next month is to contact those people on a chronic disease plan who haven't been in for review in the past 6 months and get X number, and we'll review that within 3 months, 1 month. So clear guidelines to which we can operate. And then how do we comply? Well, remember that there will be compliance issues with regard to Medicare and the MBS. So within general practice, from July 2020, in order to be eligible for telehealth, one face-to-face in the previous 12 months. Difficult for new practices, difficult for well patients as well. Males 20 to 45 perhaps are a patient of your practice, but rarely go and see a GP or rarely go and see allied health or that sort of thing. So that goes back to, as you said before, if we can identify those people and get them in. And I'll use myself as an a real example, having recently moved from Victoria to Tasmania and getting a new GP down here. Early on, April, May, I was able to get some basic repeat scripts for some basic medications. But after that, because I actually had been new to the area, I actually, in order to continue to be able to take benefit of telehealth, needed to actually make sure that I went in and face-to-face, met the GP, saw them, and that sort of thing. So these are the things that we need. If we operate smart and work smart, we can find additional appointments from within our own patient base. So as I said earlier on, your strategy is your strategy. Every practice is unique, and I've come to realize this working with so many various practices. The way you operate, you open 8 till 4, and you open 7 days a week, etc., etc. So you're unique, your patients are unique. What you decide is what's going to work, hopefully, for you. So if we say that our strategy is that we want to increase our throughput by 10 patients per day, and we're going to include 1 new patient. So we're not going overboard. So we're saying, look, from those 10, we can probably get 9 from within our own patient base. 1 new patient, half are going to be face-to-face, half are going to be telehealth, chronic disease, etc. We're going to budget an amount of $1,000. For the first month, we're actually going to review how we're going weekly, because it's probably going to be important in the early stage to have that frequency of review closer. So weekly. You might say for the first week, let's do it on a daily basis for 2 weeks, and then weekly. Once again, what works for you will work for you. And we might have a particular practice team that we have from within the practice that's actually going to do that. So it could be a manager, it could be a nurse manager, a nominated nurse, it could be a practitioner, it could be somebody from the admin team. And I think it's critical that whatever type of practice, if we've got a team, that we include someone from our admin or reception, because often they are the first person that the patients contact, speak to, and they see a lot of things that we as practitioners, managers, nurses, etc., allied health, can miss because we don't actually talk to the patient at the coalface. And what patients are saying to staff at the coalface will often be different than what they say to their doctor or their physio or the manager or that sort of thing. It's the admin staff who cop the brunt. So important to have one of those as part of your team. So we've looked at where we are, we've decided where we want to go to. Now we actually have to create the plan of actually how we're going to achieve our strategy. And for me, some of the key things really at the moment around this are, we've got to let our patients know that we've got a safe environment and they are safe, and we are looking after their safety, our staff safety, our practitioners' safety. We've also got to let the patients know that we are actually open, because there was a period then perhaps when we weren't. So we need to actually let them know we are back open for business. And not only are we open for business, but we can now provide you with more options on how we provide that service, whether that's face-to-face or whether it's telehealth. So how might you do that? And I think one of the easiest ways, and I worked with a doctor once who was really into his video. I think video is a really key component how we can promote our practice. And that can be as simple as utilizing your mobile phone and getting your practitioners to do a 30-second video, letting their patients know we're back open, I'm here, I'm available to see you. Please, as part of your good health, you need to contact the practice so that I can help you and continue your ongoing care. A really powerful tool. As I said, that can be done through smartphones and the video, upload it to a website if you have one. Or there's more professional products. I think Vimeo at the moment, you can go online and make videos. Can also say the videos are not only handy for this current crisis, but are also a very useful marketing tool for your practice as a whole. And if you're using that, if you've got your website or a Facebook site or something like that, video will actually enhance your appearance within searches and how it's taken. So video is a really, really powerful tool. There was a GP that I worked with in Melbourne, George Forgan Smith, who's known online as the Healthy Bear. Everyone wants to look at how you can actually utilize video to promote individual practitioner services, etc. A really worthwhile website to look at. That's the Healthy Bear or Dr. George Forgan Smith. So we created a plan. We said, okay, look, we want to do that. We've let our patients know. Then we might say, do we actually want to SMS all our active patients or focus on a particular cohort that we may well have seen? That could be the 75 plus. Could be people that we haven't seen for 6 months. Do you utilize tools to go those? And as I said, if it's chronic disease in general practice, just utilize the practice nurse, because the practice nurse can phone them if they're on a chronic disease plan and bill them for that contact. Similarly, if it's a practitioner or a GP, we could actually, and this is where patients may well have been in, or they've been in and they've had results done and we're following them up. Once again, let's change the paradigm whereby there used to be no funds for a GP to contact the patient to discuss results. Now there is. So the importance of that is if they've had results, you could phone them, discuss their results, and also emphasize the need to come in and see us face to face, talk to us, etc. So, and it's amazing having experienced and spoken to patients where the doctor, allied health or whatever, has actually phoned the patient, and it's actually them at the end of the line talking to the patient. The satisfaction level goes through the roof. So, my doctor phoned me. Wow. So I said it might be we're looking at all our active patients who have not been seen since the 1st of March. We may well have, during this period of time, deactivated or suspended recalls and reminders. Now is an ideal opportunity to look at reviewing those, your reviews, reminders, etc. And it may well have been that yes, we kept the urgent recalls, but there may have been things like skin checks, an annual follow-up, a particular service that you haven't provided for a particular point in time, that we now reactivate those and we actually send those out to patients. If we are going to do that, the other critical thing to actually take consideration of is how many of those, or how many patients are actually involved in that cohort. Because if there's 100 or 200, you don't want to send them all out on the same day at the same time. You'll have issues with one. Next thing you'll see, your receptionist will be just flooded with calls from patients trying to get in or responding to your reminder or your recall. The second point with that is that if you do get a significant response to those reminders or recalls, your capacity is likely to fill up very, very quickly, and you won't actually be able to offer a timely appointment. So say you might have, 500 that you're going to do. What you might actually do is say, well, okay, over the next 5 weeks, we will send 100, at a particular time at weekly intervals. And think about the time that you send them. Don't send them at 9 o'clock in the morning or 4:30 in the afternoon. It may be, when is there a quieter time within your practice that if I do send out these reminders, that the calls coming in for patients are not going to be in my busy time, or I have capacity, it's my quiet time, so I can actually deal with those particular queries from patients. So we might say, well, okay, look, for our GPs, what we're going to do, we're going to phone 3 to 5 patients per day with results, plus seek to get a follow-up appointment. So basically, with a standard consult, and if it's an eligible with a bulk billing incentive, that's $45, which over a period of time may be $750, $1,000 a week. So potentially, that could be, an additional $50,000 per annum from just getting on the phone and actually doing it. Similarly, in general practice, if we have a practice nurse, they've got to contact 10 patients a week, and if you have chronic disease, then they can bill that time as well. As you said, if the potential issue is, with a CBD practice, it may be that there is a significant cohort of your patients who don't have chronic disease, but there will be those that are there. I think the key thing, and this is whether we're trying to build capacity because of a pandemic or just because of trying to improve financial performance and patient care, patients on chronic disease, team care, GPMPs, practices generally do a very poor job in getting patients back for reviews. And that's shown, widely on the MBS with the number. If you see the number of care plans and team care that are done, how many reviews are done, there's just no correlation to what's eligible and what's billed. So really, that's one particular area that you can also look at with regard to getting patients in for chronic disease. The other thing I think which is really important, and we're talking about how we actually involve our involve our staff. If we're going to adopt a policy to get more patients in, and we've got a strategy to do it, then we've got to make sure that the people who are going to take the majority of the calls, i.e. reception, are aware of that strategy. They need to be able to deal with calls from patients that come through. Not only does it help a smoother communication, better communication at the front desk, but it also provides a great deal of empowerment for your reception staff that they are actually aware of what's happening. So if they know that at 2 o'clock on a Tuesday, we're going to send out some targeted reminder calls. So expect to get an increase in phone traffic between 2 and 3 o'clock. They're aware of it. And if they're aware that we're getting more people in for particular items, then if they actually understand what those services are, not only can they provide a better service, but they may be actually able to understand and so they've got a superior product knowledge, but they can also do the McDonald's. Do you want fries with that? If we bring that into practice, that yes, look, we may normally bring somebody back for a particular service here, but that service may also mean that they're eligible for, service B or service C, or in an allied health, if they're coming for a particular treatment to a particular area, there may be age or there may be ancillary items that may be able to be supplied by the practice that will benefit the patient. So if your staff understand and know, then they can, at times help you with that superior knowledge and also upsell the service. We can also in the practice utilize software to help us. So common ones, and I know that your PHN support both Polar and PenCat. So some of those tools can actually, if the staff understand, patients may be eligible or due for, they may have booked for a standard consult, but they may be eligible for up another particular service. Some of the other newer data integration or analytical software, Cubico, DCP, which is Doctors Control Panel, Inca, which is the old CDMnet things, are tools which can identify and analyze your data. And then some of the common software packages, especially in general practice around best practice and medical director, have some basic analytical tools. So we can use smart analytical tools to do that. So we've looked at where we are, we've decided what we want to do, we've come up with a plan how to get there. Now, how do we actually deliver it? How do we actually give that service to our patients? How do we delight the patients? And as we said, how do patients feel if their GP or health professional has actually phoned them? That's a real buzz. Instead of, they often hear, well, we can never speak to our doctor. Imagine if the doctor phones to them. So that starts to, not only benefit the individual patient and the practitioner, but those patients will actually, promote you. How do they feel if, so they're being seen promptly, why do I have to wait outside? Why do I have to wait in the car park? Well, if it's safety and it's explained to them, and if it's explained to them before they get there, the process that may be involved in this particular point in time with your service, then what's going to happen? Those patients who are satisfied are going to tell their friends. My doctor talks, my doctor actually phones me or etc. I'm safe in that. So they can promote. They can also be part of your promotional activity. But if we don't, and we're providing poor service, then as we know, and it's an old marketing thing, that they're more likely to tell 10 patients or more patients that it's a poor service. So as I said, easier to keep your patients, your current patients, happy, exceed their expectations, and they will also promote you to their friends, colleagues, etc. And as we said, if it's in CBD and it's in a workplace, what's better than, excuse me, if they're seen via video or telephone, they don't have to leave work, it's done promptly, it's done safely, the GP gets back to them, then they will obviously be happy. And what does that mean? Well, it means that the income will increase for the practitioner. And as independent practitioners, obviously there's a service fee back to the practice, so the practice will benefit as well. As you said, the other thing is that as we've actually informed staff and brought staff along with us, kept them informed, told them what's happening and involved them, the staff actually enjoy their job as well. So as an employer, you become a preferred employment site for potential staff coming through. So the job satisfaction. So also as part of delighting, we actually need to review and measure what we've actually said. And that's why I said before, it's really important that we create measurable targets, as in quantum and time. Now, I've just pulled this screen from Cutico, and this is the type of thing that's now available for us within practices, whereby they can look at particular data. So this is looking at new patients, so you put in the criteria. So this year, the number of new patients that have come through and how many have actually come back, 574 new, 65% have been repeat. And then the bottom graph with the blue and the yellow, how they're booked, telephone, online. So tools are available to help us assist. Similarly, we can actually look at to say, well, okay, real time, what's our booking, what's our capacity rate, booking rate, income, patients per hour, did not arrive rate. So we can actually start to see in real time and measure how we're actually performing. So we take, look, we're at 84% capacity, we've got a 7% did not arrive rate. If we had that, we'd obviously be looking at why. And then we can also look at other things in breakdowns by practitioners. So, as I said, there are tools available that allow us to look at how we're actually performing. And so once we've actually reviewed, measured, and building it, then also I think what we need to do is celebrate success. With our team, don't be afraid to say, hey guys, we actually got there. We've achieved what we wanted to achieve. Let's keep going. Let's keep building. Let's keep working on this, and celebrate. So now that hopefully we can have a bit more group gatherings, then yeah, we can actually celebrate the things that we've actually done and how we've got there. So that's really important. So I think the key thing, especially general practice over the next, till the end of March, is telehealth is here to stay. As much and all as this has been a particular drain on the health sector, the health budget and that sort of thing, it's amazing how quickly changes have come into the health sector over the past 4 or 5 months. There is funded, telehealth, there's improved mental health capacity and services. So, and it's been bipartisan. These things have been introduced. The politics was actually taken out of health for a short period of time. So how are we going to cope moving into the future? And the things that we are now starting to have to look at, as some of those incentives were taken back, around the double rebate on bulk billing, the bulk having to bulk bill, telehealth, etc., that we now need to look at both the human side, as in our staff and our patients, and the financial aspects around private bulk bill, private health, etc. How are we going to incorporate telehealth into our normal appointment schedule? And if we think about that from not the budget just recently passed, but from last year, voluntary patient registration in general practice was targeted, and it was due to come in July. It's now been pushed out. So patient registration, voluntary patient registration in some form will be part of the general practice landscape in the not too distant future. Perhaps we may want to look at how we look at our patients and we register them, and how we're going to ensure that they build loyalty with our practice and we retain them in the practice. So maybe we even start looking at some form of, getting our patients to agree that, our practice is their regular practice, and, we have regular GPs. We need to think about it. Now, we also need to think about, whilst the telephone has been the most significant use, there will be a push, no doubt, for video. And one of the services that provided Health Direct, which is a government service or a government product supported by PHNs, is a video product that's available there for telehealth. And I was reading, and I think it was one of the journals this weekend, I think it might have been Pulse IT, that Health Direct is now incorporated and has signed up with the interpreter service, so that it can actually be video with interpreting. So it's going to be an important part of how we develop and move with our practice. So in coming to the summary, what we've said is we've determined where we are. So that relies a lot upon our data quality. So we need to have good data and quality data to ensure that we can actually work out where we are. Then we could decide where we want to be. So we've got to quantify that, and then develop strategies for our patients, and we deliver and delight our patients and our staff with improved performance, safe and exceptional service. And remember, within general practice, that these quality improvement initiatives can also be utilized as part of the QI-PIP. So if you improve with this and do a quality improvement, don't be afraid to utilize that as part of your QI-PIP. So we work smart. And I say a lot of the time is as managers, we can be pretty quick to blame our people, but often it's actually not the people that are the fault. It's actually the process that we have there. And then finally, the 50, and especially as we come to closing on tonight, and it's about 8 p.m. And maybe some people already have already done it. So I think the 50 that we've is that perhaps we might be able to celebrate and have a drink. We've actually earned one for what we've actually done over the past 6 months to deliver services to patients, to keep our staff safe, to keep our practitioners safe in a really testing and trying time. And I think, as well as that, is that I think that it's important that as individuals, and whether we're a practitioner, as in GP, allied health, practice owner, practice manager, receptionist, we actually need to take some time out and look after ourselves. This has been one of the most, if not the most stressful times in health that we have actually had to endure, and we have been at the front end. We need to ensure that we actually take care of ourselves so that we can continue to provide services to a quality level in a safe environment. There's some contact numbers there. I see Bertha sent something through. So we've got a few minutes if people have particular questions. Happy to answer if they are there. We've covered a fair bit. I think it's all about planning, and it's about understanding who you are, what your practice is, and I said, do we need new patients, or can we build on our current patient database?
Thanks, Brett. I've got a question here. Can you share a spreadsheet to help with goal setting and accountability, or are there particular tools that you can recommend?
Goal setting accountability, I think that if you went back and we looked at, for example, if we said a nurse, and if this is from general practice, if we said a nurse, they might have to contact 10 people, identify and contact 10 people per week for that. I can find something that I probably have and send it through to you. But because the KPIs will probably vary from practice to practice, and depending what your plan is, really, if you've actually quantified what you want to do in a time frame and who's going to do it, that really becomes that spreadsheet. So reception, A, B, C by X, Y, Z, and yes if they meet it or no if they don't. So I think you can create that from within the way the practice sets it up. But I can have a look around and send you something else through.
Yeah, if you do, that'll be great. We can send it out to the attendees.
Yep. I'll make a note of that so I don't forget.
Thank you. And does anybody else have any last minute questions? Oh, here we go. Most of these strategies will work for GP practices, example, calling patients with results and getting paid, but this isn't available to allied health without a GP allied health plan.
Correct. So what I would say to the allied health people is if you review the patients that you have seen from particular GPs, and probably most allied health would have particular GPs that refer through to them. Part of the issue is that they're not getting work is because the patients actually haven't been to their GP. So if you can contact your GP practices or the manager there to actually find out particular patients if they're coming back and that sort of thing, I think that would be the start, because once again, you've already got a group of patients who are coming from particular practitioners. And I think part of the issue has been that those patients just haven't been going to their practitioner to be seen, or it's being done via telehealth. And it's perhaps for the allied health to let their GPs know that they are back working, providing services, and that they're safe. And there's also nothing to stop them contact, SMSing patients that they've been to, just to say, look, we are back here. Have you seen your GP? Do you need to see your GP? We're here. We're safe. We can help you.
Great.
I understand that. My sister-in-law is a physiotherapist, and for a long time, COVID really hindered them because of the physical contact, and that. So really, what they're finding now is that they're having to let their patients know that they're back in business, and also let their patients know that they're back in business. They may need to see their doctor to get services, or for the allied health to contact their GP or their common referrers, because all GPs have common allied health that they send to, or perhaps it's something, I don't know how the PHN there works, if with newsletters and that sort of thing, to actually be able to say that physiotherapy, physiotherapist X, Y, and Z is operational. That would be something that the PHN may need to look at.
Great. We'll just wait a few more minutes and see if there are any other questions. But if not, thank you, Brett. That was very informative, and I think that was a really good presentation. So thanks for your time.